Lisa Miller. I'm the program director for the Preventive Medicine Residency Program, and I'm also the Associate Dean for Public Health Practice here at the School of Public Health. And welcome everyone for joining us today. I want to give you just a little bit of history about this. I think those of us who have been here for a while take this for granted that we understand what this talk is, but let me just say that this is a yearly talk that we do to kind of kick off the year of seminars, and it's called State of the State or State of Public Health in the State. And we've been doing this for some years now, and it's traditionally co-sponsored by the Preventive Medicine Residency and the Department of Epidemiology. So it's a yearly event. And each year we invite the Chief Medical Officer or another physician from the State Health Department to give us an update on the state of public health in Colorado. There's obviously much to talk about, and we are very excited today to have with us Dr. Eric France, who is the Chief Medical Officer at the Colorado Department of Public Health and Environment. Dr. France is obviously actively working on the COVID-19 response, helping to create the community standards of care. He works closely with the governor's office on pandemic response, on vaccine education and allocation. And prior to joining CDPHE, Dr. France served as the West Region Medical Director for Merck Vaccines in 2019, where he traveled to the West Coast to help care delivery organizations in their efforts to improve vaccine delivery. He was also a physician researcher in the areas of vaccines, cancer screening, tobacco cessation, and was the Chief of Preventive Medicine and the Director of Population Health and the Executive Director for Sales and Marketing during his 25 years with the Colorado Permanente Medical Group, which is the physicians of Kaiser Permanente. I will also say that Eric and I overlapped in our preventive medicine residencies many years ago at this institution, and it's so good to be seeing and talking to you again, Eric. So with that, I think you will be able to share your slides, and I will mute myself and let you take it away.
Thanks, Lisa. And thanks everybody for being here today and for inviting me to come do this kickoff for your seminars. As the title described it, and Lisa described it, is the state of public health. I am new to this role. I've really, as you just heard, I've been in this role since February of 2020. So my timing was impeccable for looking for a public health experience after doing population health at Kaiser Permanente for many years. Here, just again, is a little bit about my background. Trained in pediatrics and then did the preventive medicine public health residency with Lisa many years ago, then to the Permanente Medical Group, where I worked as a pediatrician, a physician researcher, executive, as you've heard. So that's just maybe a plug to show too the interesting careers that we can have in public health. That it can be much broader than maybe what we think it could be. And certainly I've had a wonderful career today, and really no different with my time here at the State Health Department. I will say that having been here 20 months and having 19 and a half of those months be during a pandemic, I don't know that I feel I'm yet the expert, the wise public health leader to speak on the state of our public health state here in Colorado. I did think it'd be valuable though to talk to you a bit about the areas I have focused on and what we've learned and what I've learned about public health in our state. First, I'll remind you all that the State Health Department, the Department of Public Health and Environment, has two broad divisions of its work. So there's the public health side of the house, and there's the environmental health side of the house as well. And from a structure perspective, I have the divisions under public health, as well as the Office of STI, HIV, and viral hepatitis report up to me, and you see them listed here, the various divisions. Then there is a Director of Environmental Health, and Sean McGrath, and the Environmental Health Divisions report up to him. So as you can imagine, over the last 20 months, my experience has focused on the public health response of COVID and disease control, also to a degree in health facilities, which licenses our nursing homes, oversees the care provided for nursing homes, as well as emergency medical services. So that's the oversight of the EMS system. Prevention services is focused on a lot of our large federal grants, like food dollars that come to the state, maternal child health. And then there is a division that focuses on data, the Center for Health and Environmental Data, as well as an office that focuses specifically on HIV, viral hepatitis. What you should also know about these programs, interestingly enough, is that on the public health side of things, our general fund dollars from the state of Colorado might explain 5 to 7% of the total funding for any one of these divisions. Funding to these divisions comes through cash funds. So if you're getting a death record or a birth record and you pay a fee to the state health department, that funds the Center for Health and Environmental Data division, as an example. Licensing fees are important for hospitals and nursing homes, for the health facilities and EMS division, for example. And so that will have a role, as you'll see in my talk today, about how we do public health at the state. My work really these last 20 months have been divided by these two broad potential categories: work that's been defined by the crises at hand, and work that's defined by priority setting done by the governor's office, by state public health, by legislative actions. And I'll talk a bit about each of these as we go through today. If you think about the experiences since February of 2020, certainly COVID is front and center for all of us. There have been some other areas that I'll talk through as well. The creation of a new office of sexually transmitted infections, HIV, and viral hepatitis. And of course, the whole question about the use of ketamine in the pre-hospital setting by paramedics. We saw highlighted by the indictments that were announced within the last 2 weeks by the Attorney General's office, but certainly became part of my work overseeing the EMS branch of the State Health Department. So we'll talk more about each of these today. So let me start by giving you an update on COVID and let you know where we are today. First, I wanted to show you this rather extensive org chart, and this is a reminder of all the effort that is underway for our efforts to control this pandemic. And if you've had any experience in emergency planning, you know that we have recommended structures and processes by which an incident command center is built. Here you'll see that we have the governor at the top as our chief decider, with a policy group that sits underneath that includes me, as well as the executive director of CDPHE, Jill Hunsaker-Ryan. There are people from the governor's office. Lisa Kaufman is his chief of staff, for example. We have people from the Department of Public Safety. The executive director is Stan Hilke. Kevin Klein does Homeland Security. And then that policy group's job is to make decisions about what do we recommend as our next steps. What do we recommend to the governor when it comes to mandating vaccines, requiring masks in private businesses. And so the policy group here meets 3 or more times a week to discuss what we need to make decisions on going forward. An incident command center will have a command director, and Scott Bookman and Mike Willis are unified command center for this structure. Scott is in CDPHE and Mike is on the public safety side. So you see right away, in a time of emergency, public safety and public health are coming together to lead the efforts. And then there's a variety of these bubbles connected to the command director that are familiar with emergency preparedness. There's an information communications called the Joint Information Center, or JIC, which is where we are preparing our press releases almost every day and press conferences about what's happening. There is a finance section with all the dollars that have come in for COVID. It's quite a task to keep track of all the expenses and make sure everything's being tracked appropriately. You see today our focus is strongly on vaccination. And so we have a vaccine strategy group that oversees our outreach efforts, our community engagements. It uses our traditional immunization branch at the CDPHE to make sure that we're managing storage of these vaccines, that we're managing the immunization information system. So much work overseeing our vaccine strategy. Then over to the right of that, you'll see the Joint Vaccine Task Force. And this is really operations of vaccination. So as we start getting ready for boosters, you can imagine we have to think about how we're going to get vaccines in the right places. Where do we store them? How do we move them? How do we keep track? And how do we do all the planning? So quite a bit of work that is expressed, I think, in this org chart. And this org chart is a nice reflection of the typical incident command centers that we've learned over the last 10 to 15 years are the structures to best succeed with a response. Now, I want to go a little bit over what we typically would review and how I look at how things are going with the pandemic. Every day we have this table that's updated, and you'll see that it always begins at the top right with the total number of new cases that we've had for the prior day. And over the last week or so, we've been running about 2,000 cases a day. And so I'm always interested in just understanding what's happening with cases, in particular when you look at it across the pandemic since last March. Of course, you're familiar with this graph, and this is how we describe ourselves now on our fifth wave. The first one seems like they were rather small, though of course extremely significant for our response. March, April, and May being wave 1, July of last year being wave 2, the big wave in the fall last year, vaccinations starting in December into March, opening up of the community with subsequent wave in the spring that died off over the summer, and now a new wave that started after July and hopefully maybe plateauing, but it's always difficult to say. Why would that be the case, that we would have in this picture not a steep incline like we had last September, October, but maybe something that might be blunted? And of course, it's because of the good work the state has done and the people of Colorado have done to be vaccinated. So for persons 12 and older now, 3 of every 4 are pretty much have received their first dose. And so that's great advancement. If we look specifically to those 18 and older, we see where 76% have been received at least 1 dose. I think we're about 65% that have had full vaccination at this time. So the great news is that we have high vaccination rates, and it seems to be blunting the overall number of cases that we're seeing. Bad news, of course, is that if you've vaccinated 3.4 million out of 4.5 million eligible, that means there's still another 1.1 million people in the state who have chosen not to be vaccinated at this point. So that's in the words of Dr. Was it Osterholm, who says that there's a lot of wood to burn yet in our state, a lot of people who are potentially have to worry about COVID and susceptible to COVID. We've done a nice job with the 12 to 17-year-olds compared to other states. 57% of those 12 to 17 have been vaccinated with their first dose. And completion rates are in the 40s, as you see the dark blue being a higher rate of vaccination. So that's good. And our hope is that these numbers will continue to increase, though it's clear, as I'll mention in a moment, we're in a new phase of vaccination. I wanted to show you this slide because this is one I often look on our Colorado data website, and it may be familiar to you. There's a section about incidence, and here, this is looking at the 3-day average of incidence per 100,000 population. I focus more on the top line. The bottom line is just reflective of how is the slope? Is it a positive or negative slope in the incidence line above? And you'll see that for the region of Colorado, we are at about 25 cases, new cases per 100,000. But to me, what's more important is that it's actually been kind of flat over the last 2 to 3 weeks. And by region, I can look at different parts of the state. If I click on the down arrow to the right there where you see Colorado region listed, I can look at Pueblo, El Paso, Southeast, Northwest, and I can see what's happening across the state in a trend line that's looking at incidence. And so I am pleased to see this isn't an ongoing upward number. I think at our peak in December of 2020, we might have been around 85 cases per 100,000. And when we're at our low, we're running at 5 to 7 per 100,000. So the number of cases is encouraging to a degree right now. We've been concerned, however, about schools, right? And with schools in person, we are finding that the highest rates of cases per 100,000 have been in children under the age of 18. You see 6 to 11 and 12 to 17-year-olds in this graph, and both above the 18 and older category. Again, though, the numbers are coming down in the last week or two. I'm not sure that I'm confident that they will stay down in the school setting as students get together. So we're paying close attention to what's happening in the schools across the state to understand where cases might be. The other thing, of course, I look to this graph, this table, and I want to understand hospitalizations. Hospitalizations, of course, feel like a hard metric. Cases can vary and be biased by whether or not people get tested or not. Hospitalization feels a little bit more firm. If you're hospitalized for COVID, you probably are a hospitalized patient, and people aren't staying home and avoiding being hospitalized. And these numbers too have been going up. Here again are the numbers currently hospitalized across the 5 waves. And you see that at our peak, we were at 1,850 in the hospital. And most recently, we're up to 900 people. I think that's above the peak that we had in April and May of last year. Daily hospitalized patients is one metric, but the other is to know how many are admitted every day. And when we look at admissions, again, it looks like maybe over the last 3 weeks, we've had a blunting of the case increases. And so that steep slope that began in August seems to have translated the second half of August and into September into that blunted flat line of admissions, which is encouraging. And I think, again, is a reflection of our vaccination rates and what it's been able to do to really use pharmaceutical interventions, essentially, to blunt the pandemic curve. Of course, deaths is also an important tracker data point, and you'll see that in August and September, our rates have drifted upwards, certainly not at the rate that we saw back in November and December. The last week or so, we understand are not fully reported. So you'll see that gray bar on this graph that always reflects the uncertainty of the most recent data, but certainly a increase in death rates from 5 or 6 to 10 to 15, and the occasional day of 20 deaths now reported in our state. So hospitalizations and deaths are something we watch very closely. And of course, looking at testing positivity, the percent positive, as you see at the below right, we've been running at about 5.9 or 6%. And we have this graph that we follow our percent positivity. And this, as you know, gives us a sense of how well we're doing with our general testing. Are we testing enough? The goal is to have percent positivity below 5%. And to do that, we do it by ideally increasing the denominator, having more people tested, and therefore having a better handle of who's ill, and hopefully quarantine and isolating those folks to have them reduce their transmissions. So we've been now again kind of just puttering around 6%. When it goes up high, it's a worrisome potential sign that the epidemic and pandemic is expanding quickly. We do also look at our state testing lab volume. We're doing over 7,000 tests a day, and the TAT turnaround time, as you see there, is at 1.6 days. We've offered, through federal funding, broad opportunities for schools to test their students. Of the 2,000 schools in the state, just under 600 of them have opted in for routine testing and are becoming enrolled into this new testing program. We pay attention, of course, to our supplies for tests, over 460,000 Binax tests that we have on hand. We're getting 100 to 200,000 more a week. Our own testing sites are at about 27% of their capacity, so we have plenty of capacity for testing. And our partners, Makeid, COVID Check, and other vendors are all turning around test times quickly. So those are the things I'm looking for every day as the Chief Medical Officer. What's happening with cases, hospitalizations, deaths? How are we doing with our testing and our testing supplies? We've done a lot of work over the last couple of months to really try and improve vaccinating the unvaccinated. And it seems clear that those who are unvaccinated are not particularly interested in becoming vaccinated at this point. We've given plenty of opportunity to become vaccinated. And we try and meet them where they are with our mobile buses, doing things at work sites. We recognize that this phase of vaccination is really convenience, communications through marketing plans, and confidential or the kinds of conversations with your primary care doctor and other providers are really what's going to help. And we've done some work, as you know, to try and get people vaccinated through financial incentives. And before these took hold in end of July, we were doing maybe 3,500 vaccinations a day. With some of these giveaways, the numbers went up to 5,500, 6,000 a day and stayed at that plateau for a number of weeks. We're just kind of finishing off some of these financial incentives for vaccination. So it's a different phase where more than ever, vaccination will be something that we have to promote to occur in doctors' offices and through other trusted partners. And so over the last 30 days, we did some hard work to build a new grant program for primary care. As of the summer, it was a small number of primary care clinics that were actually offering the vaccine. You couldn't get it at your doctor's office. And yet in rural settings, in those parts of Colorado where there's a lot of hesitancy, having the conversation with a trusted doctor, we believe is key. And so this new primary care grant program will pay up to $60 million to help primary care practices establish that necessary infrastructure. Do they need refrigerators? Are they connected to our immunization information systems? Have they the supply of vaccine? Can they give their first doses? It also will pay them for improving vaccination rates within their panels, more of a high level, small payments that say, you know, if you can go from 50% to 60%, there would be some remuneration for hitting that goal. And our hope is that really the goal here is as much about building out a vaccination infrastructure in primary care clinics as as it is specifically improving the COVID vaccination rate. Pediatric offices should be getting ready for vaccinating 5 to 11-year-olds. Should that vaccine for COVID be licensed by the end of this year and early next year? Do they have the infrastructure, the people, the processes, the technology to do that work? The flu vaccine certainly is another big one that we'll want to be sure that they're providing as well. We also have granting now for opportunity to improve vaccination rates in marginalized communities. We did a lot of work with pop-up clinics and partnerships to improve vaccination in marginalized communities. We have funding to support vaccine education administration up to $16 million, a program to pay for navigators for engaging communities. And these grants will be coming out of the immunization branch oversight that I first showed you on that org chart. So a lot of focus in the more mature kind of space that we're in now when it comes to improving vaccination work. So all of that, what does COVID look like over the coming months? Well, there are going to be these persistent and potentially increases in hospitalizations. If cases continue to spread amongst predominantly the unvaccinated, the million Coloradans who've chosen not to be vaccinated, they will arrive in the hospitals. We have 10,000 hospital beds, 2,000 ICU beds, and so far things are looking more promising than a year ago when we were worried that we might overwhelm bed capacity. Challenges for hospitals today are staffing challenges and burnout challenges. Moral distress, caring for people who are very ill in their ICU and hospital who've chosen not to be vaccinated is a challenge. And many of our hospitals could open more beds if they only had the staff to do it. Staffing is a challenge right now. Certainly, we're all focused on the K through 12 experience. One of my interesting learnings in state health, public health, is that when I would get on a phone call with local public health directors, they would speak most of the call around school districts in their local area and plans and work. And it opened my eyes or emphasized the fact that much of schools is a local plan and a local effort. School districts, of course, work very closely with their local public health agencies to make plans, and guidance from the state can help drive it, but ultimately these are local decisions about what school return looks like. We expect at the end of this week, when the FDA meets on Friday, that regulatory allowance will be given for a booster dose for the Pfizer vaccine. Though I'm not sure what age group, I doubt similar booster allowance will be given to the Moderna vaccine or the Johnson & Johnson vaccine at this Friday's meeting. My assessment is they don't quite have enough of their data together, but we'll see. I assume too that the advisory committee on immunization practices that makes recommendations to the CDC will meet likely Saturday or Sunday once the FDA has met this Friday, and we may, as soon as next Monday, be providing boosters for certain Coloradans. This would be a third dose to counter the potential for waning immunity. There is a sense that it may be limited to people who are of older age or living in residential care, as well as healthcare workers, but we don't know. Either way, we're planning at the state with our partners to be ready to spend the next 3 weeks, the 20th through the 11th, to offer boosters in all of our assisted and residential care facilities. Another big area of focus I'll come back to are monoclonal antibody treatments. That will be something we'll be looking as a way of treating people who are positive for COVID or potentially a post-exposure prophylaxis. That will become more common, I think, in the coming 2 months. Looking a little bit longer, we certainly are laser focused on preparing for flu seasons. We had very good flu vaccination last year and very few flu cases in the hospital last year. I've never seen anything like it over my 30 years. We'll continue our work in primary care partnerships. And really, I think I'm recognizing that in general, if you're unvaccinated, COVID's going to be coming for you. And I can't convince an unvaccinated person to become vaccinated. It's certainly a choice. And so that is a choice then to either do your best to stay away from being exposed or recognize that you're likely to get COVID in the coming months. And we need to try and manage things so that not everybody gets sick at once who's unvaccinated. I don't want it to overwhelm our healthcare workers or our hospitals. And so if interventions occur in the coming months, it will always be with the thought of protecting our hospitals, reducing death, protecting our healthcare workforce. And if the speed of uptick in cases is at a higher level, then certainly we'll be wondering if there are non-pharmaceutical interventions that should be required. So just a couple comments here about my experience with these monoclonal antibodies. They were first made available through EUA last November, so 10 months ago now. And we quickly worked at the state to try and make them available. It was a challenge because there were high hospitalization rates at that time. And once those started to settle down, we needed staff to do vaccination. So we had a limited resource, which are healthcare workers, and we had hospitalizations and vaccinations and monoclonal antibody treatments potentially all needed to be done by the same workforce. So it was a challenge. The data was early back in November. Some of the physicians weren't particularly excited about the results, but really what we found over time is that these monoclonal antibodies, these MABs as we call them, can reduce hospitalizations by 70 to 80%, as well as reduce your symptoms. They are effective against the Delta variant, and we now have 3 different therapies that we can use, and these are antiviral therapies that can be done on the outpatient basis rather than being hospitalized. And now we know they also work as post-exposure prophylaxis. So if somebody has an outbreak in their home or in a residential care facility, treating those who are exposed will reduce hospitalizations by half. Challenge, of course, was that these were infusions, and bringing someone into an infusion center who has COVID was, of course, maybe not a wise idea, given that people in infusion centers have cancer or immune compromising conditions. I think what's become more clear now is that with the Regeneron product in particular, we can use subcutaneous injections. There's 4 injections required, 2.5 mLs each. And we have to get over the cultural hump of saying, wow, that sounds uncomfortable, to recognize that it's probably way less uncomfortable than being hospitalized with COVID. So, and if you do a subcutaneous infection, now you can start thinking about a larger plan of state sites. And in Alaska, in Florida, in Oregon, there have been these larger treatment sites that have been built. And that is something that we're currently exploring and hope to be able to offer over the coming weeks. Our website at the state will show that we have over 30 infusion sites available. I think there are over 90 places that are being shipped. So we don't have all of them on our website at this point because it's not required. It's become more of a standard of therapy, of care. And the demand has gone up considerably over the last month, where we might have had 50 to 70 doses. Now we have 400 to 500 doses every week, and we may not have the number of seats and supply quite available for the demand. So we're working on this new strategy of potentially setting up treatment sites where we can do larger numbers of these for people who are at higher risk for hospitalization from COVID. That's my update for COVID, and I'd like to talk about the next area of focus when I first arrived, and that was the Office of Sexually Transmitted Infections, HIV, and Viral Hepatitis. And this office was actually part of a division, Division of Communicable Disease, and we've pulled it out in part because of the complexity of the care and program that this office brings to it. And I bring this up as an example in part to kind of describe to you public health at the State Department level from a division or an office perspective. As you saw, I had 25 years with the Permanente Medical Group, and at KP, my work was often about hitting goals, whether it might have been on cancer screening, smoking cessation, blood pressure control. And for each of these areas, we start with these basic questions. Where are we going? What are we trying to do? How are we going to get there? How are we doing? What kind of data are we tracking? And we would be sure that we had the people needed, the processes, and the technology so that over time, we could build colorectal cancer screening from 45% to 85%, for instance, or hypertension control from 50% to 85%. And in order to do that, you need to have a strategy. You have to know where you're going. You need to have clear steps about what you're going to propose and how you're going to make that work. And then you need the right kind of data that shows how you're doing in your strategy and making the appropriate kinds of changes as you go forward. So if I bring that general thinking to HIV prevention for a moment, we should have a goal for the state that says our baseline new cases of HIV are 470 a year. How do we drop that from 470 to 400? And how do we do that in 2 or 3 years' time? What people, what processes, what resources do we have? And how do we use those resources to do that? What we find, however, and again, this office is much like the other divisions, that there is a existing institutional public health, as I describe it, that has very structured funding and very structured success definitions that are potentially not as clear as the one that I described starting forward. So as an example, funding for HIV prevention, care, and treatment has a variety of different sources. There's HRSA dollars for care and treatment through the Ryan White program. There are CDC dollars for prevention, for syringe exchange, for surveillance data. There's state dollars that come from the Master Settlement Agreement on tobacco. Those dollars are declining as fewer people smoke tobacco. There's an AIDS drug assistance program that's funded through the state. We have a rather complex process of getting federal and state dollars through a rebate for the drugs that are purchased and distributed through the state. So if the retail price is $1,000, but we can buy it $750, then the $250 difference is considered a rebate that comes to the state. And there are federal dollar rebates and state dollar rebates, and each is used differently. So each of these is rather complex. The HIV prevention office, I should say, in general, has a budget of about 56 million people. And I'm sorry, $56 million, with about 80 people now, 70, 80 people working it. Over 80% of the dollars come from the feds or the CDC, of course, and then go directly out into the community. And so if you think about it as an entity, then this office needs to be very good at meeting any expectations of the funders, just like any of your grants would expect. And because so much of our dollars are passed through the state, we need to be particularly good about writing the contract with the contracted entity out in the state. We need to be able to manage that contract. We need to be able to show the feds that we manage those contracts well. The feds may say, we want these data sets. And so we need to be sure we're collecting the data and providing the data. And then, of course, we need to be sure that we're meeting the needs in the community with the programs that are coming. Are we getting people early into treatments for HIV once they've been diagnosed? Are we doing the case ascertainment and finding other contact folks? And so all of this to say, this is what I see and I learned being new to the state health department is what I might call institutional public health, where dollars come in, they're very well defined about how they should be used. They go out into the community, and at the very first level, the success is not about reducing the number of HIV cases in the state. The first level is, are you tracking the dollars well? Are you writing the right contracts? Are you managing your contracts well? Are you providing the CDC with the data they need? And of course, you always have to do that as the base infrastructure for overseeing such important work and important dollars. And then once that's all in place, you need to then come up with a statewide strategy that's agreed upon by all the entities that are receiving these dollars, with specific strategies, therefore, to move forward. When I arrived in February of 2020, a lot of the infrastructure in the office needed to be redone. There were a number of important leadership roles that were vacant that needed to be hired in. There were a lot of new trainings and programs in place. And so part of the work as a state CMO or a public health entity is really being sure you're building the bones that you need to do everything right from your federal expectations. And that was something I wasn't aware of, and requires a certain amount of time to build those bones, and then move into that more traditional space of defining your mission, figuring out your strategies, collecting the right data, and driving so that numbers improve over time. So another surprise, or crisis, I should say, was EMS care in the state of Colorado. I think it was in the summer of 2020 that the executive director asked me to look at our oversight of the EMS system. You may remember that the death of Elijah McClain occurred in August of 2019, and it was with Black Lives Matter focus in the summer of 2020 that arose appropriately the tragedy of Elijah McClain. And so the state health department actually oversees the licenses of paramedics. And so the ask to me was to say, let's look at how ketamine is used in the state. You can see some of the headlines here. We determined in July of last year that our department should do an investigation on the use of ketamine and the oversight of its use in the state. This, though, really expanded over the year to more broad issues of EMS oversight. So the Division of Health Facilities and EMS is responsible for overseeing the EMS services. My medical license, a pharmacy license, a nursing license, those are all managed and overseen by the Department of Regulatory Affairs, DORA, here in the state of Colorado. However, the paramedic's license to practice as a paramedic is actually managed by the Department of Public Health and Environment and sits here in this division. And this division has by statute, a council called Emergency Medical Practice Advisory Council, or MPAC, which is made up of governor-appointed physicians and specialists who define the scope of practice for an EMS provider. You can intubate if you're at this level of a paramedic. You can do an IV and so on. And that scope of practice, of course, is defined by national standards, but ultimately overseen by this council. The council can also provide a waiver to allow an ambulance agency, the medical director who oversees those EMS providers, to apply for a waiver above the basic scope of practice. And so the ketamine waivers would arise in this way. So ketamine was used for excited delirium syndrome, a state of excessive extreme agitation with potential hypermetabolic conditions and the potential risk of death. And that was how the waivers were allowing ketamine to be used. All ketamine waivers in the state have since been suspended for a number of months now, in part because of a new law in the state that was passed over this last session. I learned a lot about our EMS system through this work. I have a panel that's doing an overview of the use of ketamine. We're finalizing our report and hope to have it out soon. But at the broader level, it's not like many of us think about how is the oversight of the ambulance systems in our state. We probably all assume it's probably not dissimilar to what happens for hospitals or for other healthcare systems. But actually it is quite different. We are only one of 2 states that does not license the ambulance agency at the state level. So we really cannot go in and investigate some experience beyond investigating a complaint against somebody's license. We can, of course, go and investigate in our decision a hospital if we hear something that has us concerned, or a nursing home about the care they've received. But that isn't in the authority of the state health department today for a ground ambulance agency. So the complaints against a paramedic, if made to the state, can allow then the state to then investigate that paramedic. But the state isn't really exploring the agency itself or the system of care, only what the paramedic is actually doing and whether it isn't aligned with the expectation based on their licensing. So we've heard more since about other issues. Ambulance agencies can balance bill an individual. I think there was a story in the news not long ago of a woman with her foot caught at a subway, and she said, please don't call the ambulance agency because we are saving for a house or something like that. And they were worried about balance billing by ambulance systems. A good story this summer from Denver Post showing the challenges of rural EMS systems. I think last summer an EMS medical director said their EMS providers could go down and work at Walmart, make more money than they might working as a paramedic in their rural area. Issues about trauma services, and are some ambulances bypassing a local trauma center and taking it to their home hospital instead of the nearest trauma center. These are all challenges that we have going on, and certainly I didn't realize in this job I'd be learning about and working around the issues of EMS care as a large part of my work, my first 20 months. So that kind of highlights some of the things that we work on that have been really crisis driven. There are, of course, other priorities set through legislative statutes. So for instance, a new law passed creating an Office of Gun Violence Prevention. So we're tasked with building that. There are other statutes that get passed and bills that succeed that then require us to build some new office or new program of one sort or another. The governor has promoted certain goals for the agency, and then we, by statute again, create every 5 years a public health improvement plan at the state health department. And so here, for example, are some of the themes of the wildly important goals that we're working on at the state. There are 12 or 13 of them defined in partnership with the governor's office. And invariable plans of improvement, as you can imagine, with COVID pandemic hitting us at the beginning of 2020. And this is the second part of that list. And some of it is making changes in the way we do our general work in public health. And some of them are focused on new issues and some on more chronic issues where we know there's opportunity. And then the Public Health Improvement Plan, the FIP, as we call it, which we do in partnership with local public health agencies, has identified areas of focus as well for the State Health Department. They're very exciting. Beyond the COVID work, the State Health Department has declared racism as a public health crisis. We are just finishing up our hiring our new director for the Office of Health Equity. The agent in the Office of Health Equity will work across all agencies of the state. We have our own EDI director for CDPHE and making many changes in the way we do our work so that we become a more of an anti-racist department over time. A lot of focus on greenhouse gas, climate action. You may be aware that there's been work to create a new behavioral health administration within our Department of Human Services, which brings together all the disparate behavioral mental health efforts across the different agencies into one home. So that's been great work as well. So a lot of priority work to do, but my experience to date has shown that in general, some of these crises can be the driver of what we do every day. It's certainly been an exciting 20 months for me, and most of my work has been more responding to crises than it has been that higher level strategic work, and that's just a reflection of where we are in the health of our state and our country and our world. I've learned more about this institutional public health structures and how it could potentially limit the opportunity for traditional strategy work. I think in contrast to the COVID response, where there's been a lot of money, a lot of strategy, a lot of people and resources and flexibility to do what we think we need to do, that isn't how you would describe the work on smoking cessation or HIV or the built environment. And much of public health is limited by the types of grants and the expectations of those grants to date. And in spite of all that, I would just say that this has been a terrific challenge and a terrific job. And the work in public health is very exciting. And I say that not just to be sure, I'm encouraging all of us to recognize that even in the space that we've been in, this has been one of the most fulfilling, exciting, wonderful parts to my career. And I look forward to all the challenges that are coming ahead. So with that, Lisa, I think I'll stop. I want to leave some time here for questions with the group.
Okay, thanks so much, Eric. I think we could probably spend another hour on questions. I know I was jotting down questions as we went, and I have a list, and I bet there are other people that also have a long list. So we'll try to get a couple of those questions in. And if you could, it's a pretty large group, let's use the chat. And if you want to start putting your questions in the chat, I think Eric and I can both see the chat, and maybe we can pick some questions to select from the chat. And while you're doing that, maybe I'll start out with a question from my list. So I was wondering, given your connections to medical care, do you think the pandemic has resulted in more opportunities to work more closely with medical care providers? I know you gave the example of trying to implement immunization homes in more primary care practices. It just seems to me that really this has been a response of both public health and medical care. So do you see other ways that public health, maybe going forward, will work more closely with the medical care system?
Well, certainly I think that's the case. And the big driver, of course, is our connections with hospitals and the care in the hospitals. early in this pandemic, we really needed to be sure we understood how many beds we had, how many ICU beds we had, how many were filled on a given day. And so we quickly pulled together some of the very large health systems and hospital systems, weekly calls and oftentimes more. But even today, we still have a weekly call with the chief medical officers. And our observation early in this epidemic was that we have a very competitive healthcare environment, and the UC Healths and the Centuras and the SCLs were not always talking with each other. They were, competing for market share in that sense of hospital care. And so now it's a group that comes together and we talk things through. We transfer patients from hospital to hospital. We have a lot higher levels of trust in terms of their ability to manage their demand and their census. And we work very closely with them on crisis standards of care for what would happen if the hospitals were overwhelmed or if their staff were overwhelmed. So in the hospital setting, a much more close work. I think two, there's a lot more work that we're doing with the Colorado Medical Society, which is more of the traditional medical physicians and outpatient settings, as well as their specialty group. So Zoom makes all that easier as well.
Yeah, thank you. Also, I feel like we should ask from the school perspective, what should we be training our students to do, maybe that we're not currently doing? What have you seen in public health that might be lacking? What could be beneficial for us to change in the way we deliver training, either to our residents or our students?
Well, I'm sure there's a lot of training on the social determinants of health, and certainly that's a big focus on the public health efforts that we have here in the state. So being knowledgeable about that is important. I think being knowledgeable about execution and moving numbers is really important. So, the Stephen Covey of 7 Habits of Highly Effective People in 2007 became a new one called the 4 Disciplines of Execution. It was a different phrase, but it was all about how do you get things done and move numbers. And the phrase wildly important goal comes from 4 Disciplines of Execution, 4DX it's sometimes called. And so if you really do want to move tobacco numbers, colon cancer numbers, HIV new cases down, understanding the habits of execution and driving them, as I've described, would be important for students, because I think there are many things about the jobs in healthcare, in public health, where I've succeeded in my role if I've provided that data set to the CDC. Whether or not that leads to actual public health improvement, that's not how I'm judged, or I've succeeded because I've managed these contracts. So I like the idea that if there's a public health 3.0, as came out some years back, part of that 3.0 sharing should be around business execution against goals to succeed with the public health goals and numbers that we have.
Okay, and maybe we have one. I don't know if you can see the chat, Eric. There's a couple questions there if you want to pick one of those. And maybe that will be all we have time for. Maybe one that might be quicker.
The first one was about what ideas we have for transformational investments to improve care transparency and discrimination when it comes. I think this is behavioral health work in particular. And I'm afraid I'm not as looped into the ideas presented at this time. I think we certainly identified that expansion of telehealth and interstate telehealth are important opportunities. So much of behavioral health care issues are about access to care, and do we have enough resources, enough people trained to help others? And telehealth that we've learned through the COVID pandemic has really expanded the potential for behavioral health through telehealth. And so that's an important area of focus for other state agencies in partnership with us. There's a question too about whether we see more testing availability for rapid antigen tests that are free as opposed to PCR. And, you know, we're hopeful that the president's work to use his power to bring in new manufacturers will help. To create more rapid antigen tests than we have now. You know, we're a little disappointed that we actually have a lot of tests and the school districts aren't interested in testing, though we have these tests available to them. It may be that to some sense, there may be like, what they don't know is it's better not to know. If I know I'm positive and then I have to quarantine and kids are out of school, that's a problem. So we have plenty of tests to offer school districts and they're not picking them up. We didn't do any prioritizing of testing this last year. Anybody could get tested. And I think that sometimes proved challenge when we started running low on tests. My expectation this time around, if it needs be, that we will be more forceful about prioritizing, but I don't even think we'll ever need to do that because of the volume of tests that are being produced.
Okay. Well, thank you. Thank you again so much. It was really fascinating to get a glimpse of sort of how you look at COVID, how the policy system works and what you're thinking about in the next couple of months. And then also these other big issues that I think haven't had an opportunity for us to learn about, but are also really important. So again, thank you so much. Appreciate your time. We know that it's in short supply, and wish you the best in the future and the continued challenges of public health. Thanks, Eric.
Thanks you. Bye-bye.
Bye.